So we are so delighted to have with us Dr. Olufokunbi Sam, who is the Chief of the Healthcare Delivery and Methodologies Integrated Review Panel. Prior to this, she served as the Chief of the Population Sciences and Epidemiology Integrated Review Panel and joined the NIH Center for Scientific Review in 2009. She's also served as the Scientific Review Officer for the Health Disparities and Equity Promotion Study Section and served as the CSR SRO Training Workshop Coordinator. So needless to say, she is quite knowledgeable about study sections. Dr. Olufokunbi Sam earned her PhD in clinical and health psychology from the University of Florida and received her postdoctoral training in mental health services research and policy at the University of South Florida's Department of Mental Health Law and Policy. Before joining the CSR, Dr. Olufokunbi Sam was the Deputy Director of the Center of Integrated Behavioral Health Policy at GW University, where she managed a diverse portfolio of behavioral health research and policy. She was also an Assistant Professor of Health Policy in the Department of Health Policy at George Washington University. Her research focused on behavioral health policy, substance abuse prevention and treatment, minority health, and child welfare. And we are so delighted that you're here with us today. Thank you so much for taking this time to help us understand some of these changes that are going on with study sections.
Thank you very much. So I am going to attempt to manage this PowerPoint via Zoom. So hopefully I don't run into any snags, but do let me know if you're not here seeing the PowerPoint as I move through the slides. So I am happy to join you today to talk about some of the changes that we have most recently made in the healthcare delivery and patient outcomes cluster. This is a cluster of study sections within CSR. They primarily overlap across two integrated review groups, the risk behavior and health behavior, risk prevention and health behavior IRG, and the healthcare delivery and methodologies IRG. So before I get into that, I just want to provide you with a kind of broad overview around how we approach evaluating our study sections within CSR. And so we do employ a framework designed to really ensure that we are sort of providing the most up-to-date, the most effective approach to ensuring quality in peer review. And we have three sort of prongs or three approaches that we use to evaluate quality. One is really focused on our reviewers. And through this, we ensure that we train our reviewers to make sure that they're providing consistent, fair, transparent review according to NIH's review policy, federal guidelines, and our CSR's approach to review. We also try to make sure that we have a broad range of reviewers, that we engage scientists at all levels so that we don't overuse particular scientists in any particular discipline, and that we recognize sort of the multidisciplinary nature of research, and that's reflected in our study sections. We also evaluate our reviewer performance. We look at their qualifications, their experience. We look at how the sort of quality of the critiques that they provide, their scoring behavior, to make sure that they are providing as useful feedback as possible in their assessment of the applications. We also evaluate our process. And so we have been paying particular attention to the integrity of the peer review process. We have been evaluating most recently bias in review. And so we have a number of studies that are looking at potential bias in review. We also periodically look at our review criteria. We look at our scoring system to make sure that they are really appropriately identifying innovation in science, the potential impact of the applications, and the ability to really identify emerging areas of science and applications that have the potential to have the biggest impact in the field. And finally, we periodically evaluate our study sections. And in this process, we look at the scientific boundaries of the study sections that we have. We look at whether we are appropriately reflecting the scientific field, the emerging areas of science, that we are paying attention to potential still areas of science, that we have the appropriate size of the study section, that the study section has the appropriate expertise to reflect the science that's coming in. And so what I'm going to talk about today is really that third prong, the study section evaluation. So we have a process called ENQUIRE. It's an acronym, and it stands for Evaluating Panel Quality in Review. And this involves a critical assessment of the study sections by a particular scientific cluster. And the result of that process are recommendations for changes that ensures that we have the appropriate scientific scope and function of the study sections so that we can really identify high impact science. And those changes are pretty broad. Sometimes they involve modifying our review guidelines or the boundaries between study sections. Sometimes they involve getting rid of or disbanding current study sections, creating new study sections, modifying the expertise within a particular study section. So the recommendations are pretty broad. And once we get those recommendations, we go through a process to implement them. And so here is our process. The first stage is really sort of pulling together an external scientific working group. That working group consists of scientifically broad senior level scientists in the field. And they essentially look at the scientific guidelines for our current study sections. They look at the workload trend, the kinds of applications that are coming in. We provide them with a sample of abstracts and specific aims for the applications that come into each of the individual study sections. And we also provide them with some bibliometric data on the output of the study section. And they really sort of think through for each of the study sections in the cluster, is the scientific scope appropriate for that particular study section? And is that study section really identifying high quality research? Once we get recommendations from that external panel, we have an internal process working panel. And that includes senior level IC folks, representatives from the Office of the Director and CSR senior leadership. And they are really looking at the process supports the identification of high quality research. And so the input from the external scientific work group. They look at the individual study sections, their scoring behavior. We do surveys within each of those study sections. We survey the program officers that have applications in those study sections. We also do study section site visits where we do more of a qualitative assessment of the discussion, of the scoring behavior, of the culture of the study section. We also look at the early stage investigator application and award rates. And from this, we come up with some additional recommendations, taking into account the recommendations from the external panel. And those recommendations go to the NIH Extramural Activities Working Group. And this is even a senior level, high level, multi-agency policy group that serves in an advisory function to the NIH director. And they review our recommendations for study section changes. And then based on the approval of that process, or those recommendations, we come back and we engage our internal scientific staff to think through how best we operationalize or implement these recommendations. And then we get into the stage of implementation. And that's where we are currently. This is a sort of data-driven approach. We evaluate about 20% of our study sections within CSR each year by cluster. And so for this year, we had, or for 2019, we had about 4 clusters that we evaluated that comprised of about 42 study sections, about 24% of all the study sections within CSR. And the cluster that I'm going to talk with you about today is the healthcare delivery and patient outcomes cluster. And that cluster consisted of 9 study sections. As I mentioned, 2 study sections from the risk promotion and behavior, health behavior IRG, and then 7 study sections from the healthcare delivery and methodologies IRG. So we are now in the implementation phase. We have had, we've gone through the soft internal release. We have posted the descriptions on our website, and the implementation of the new study sections and the elimination of the old study sections will occur for the 2021-05 council round. That is for applications that are coming in for the October-November due dates, so the October 5th R01 due dates, and for the February meetings. Okay, and so the study sections that will be ending include these 9 study sections. Again, and I'm not going to go through each of them, just so that you know that pretty much most of the study sections within the healthcare delivery methodologies IRG will be disbanded, and we will be implementing new study sections. And so the new study sections that we are going to be creating are these, and I'll go through each of these individually. So they are sort of categorized by the level of analysis. So our individual level study sections really focus on the sort of individual health promoting lifestyle change interventions or evaluations. And so we have 2 study sections, the biobehavioral medicine and health outcomes, and the lifestyle change and behavioral health study section. And then our study sections that are focused more on the community or service level, we have 3 new study sections in that area. The science of implementation in health and healthcare really focuses on implementation science. These are applications where they are trying to use implementation science or implementation theory or strategies to integrate evidence-based interventions across different healthcare settings. And so this is really, this study section really focuses on implementation science, implementation theory, kind of what we think of as type 2 or type 3 hybrid implementation studies. We have the healthcare and health disparities study section. This is really looking at the systemic underpinnings of healthcare disparities with a focus on really access to, use of, and the effectiveness of health services and health promotion at the health system level. So this is really looking at the health system level, not at the individual level, not at the population level, but really at the healthcare system and healthcare services level. And then we have our health promotion in communities. This is really focused on interventions, community level interventions, or interventions that are implemented within community organizations or other non-clinical settings. All right, and then we have our 2 clinical management study sections. These 2 study sections are the ones that might be of most interest to you as a group, because these really focus on the clinical management of patients. One is focused on clinical management from a provider perspective in the general care settings, and that includes home-based ambulatory settings or settings that involve care teams that are oriented around primary care. And the other one is the interdisciplinary clinical care and specialty care settings. And this is really focused on clinical management of patients in the institutional or inpatient settings, such as hospital, nursing homes, inpatient facilities, and hospice care settings. So the difference between these two study sections is really sort of where the care occurs. If it's in sort of general care settings, then it's our CMGC study section. If it's in specialty care settings or complex care settings, then it's in the ICSC study section. And again, these are really applications that focus on patient care that have really sort of significant implications for clinical practice. We have two study sections that focus on health services research. The health services quality and effectiveness study section focuses on healthcare quality, effectiveness at the individual patient health outcome level. And then the organization and delivery of health services really focuses at the organizational level. So looking at the delivery of health services at the system level with a focus on financing, insurance, access, utilization, and again, provision of services, but at the population level or the services level. And then finally, we have our clinical bioinformatics study sections. These are two study sections. One is focused on sort of the development of technology, of data models, data analytics for eventual translation into or for clinical use. And the other one is really focused on clinical informatics. And so this is really sort of using these technology-based tools and approaches for clinical decision-making, clinical decision support, health IT, mobile health interventions. So these are kind of really a bit more developed and applied. One of the things that we've been very mindful of through this process is the rapid growth and the changes in healthcare services research and community-based research, and the need to really integrate across all of our study sections some emerging areas or multidisciplinary areas of science. And the big four that we are particularly attuned to are the sort of bioinformatics and machine learning, mHealth, nursing and clinical applications, clinical services, clinical management applications, our health disparities and social determinants of health focused applications, and implementation science. And in the past, these have really been siloed into particular study sections. And what we're trying to do now is really acknowledge that there are really team-based, multidisciplinary approaches in many of our applications, and that we need to populate all of our study sections with these types of expertise so that when the application is focused on a particular area that fits a study section, that we have the relevant expertise within that study section and don't need to necessarily put all the applications in one particular study section. So if an application is dealing with health disparities, but it's at the community level, it's a community-based, community level intervention, that it would go into our community level intervention study section, but that study section would have the requisite health disparities expertise. And so while we have study sections that focus on these broad areas, we are really working to populate all of our study sections with this type of expertise to make sure that we have a comprehensive approach to evaluating these multidisciplinary applications. This is just a picture of our website. On our website, you will be able to see all the study sections that are ending and all the new study sections. And if you click on any of those links, you'll get a description of each of the study sections. And then this final slide really just points you to a couple of links. One link describes the entire inquiry process and the specific recommendations that we received both from the external and internal panel. The next bullet is a link to some of the evaluations that we are undergoing here at CSR on a range of issues. If you were interested in, we have an evaluation on bias, on integrity, review integrity. So if you're interested in any of the evaluations that we are doing internally, you're welcome to on that link and see. And then the last link is just a link to our study sections where you can get a description of each of the new study sections. All right, and that's all I have for you.
Thank you so much, Dr. Olufokunbi Sam. We have a couple of questions already coming in. The first is, can investigators report reviewer bias?
Report reviewer bias?
Yes.
Yes, so we have a review integrity office here at CSR, and if you have knowledge of any reviewer bias or inappropriate behavior, you can contact our review integrity office, and they will look into that.
Thank you. Another attendee is curious why there are not interventions for the systemic underpinnings of healthcare disparities.
Can you repeat the question? Why they're not?
Well, one attendee is just curious why there are not interventions for the systemic underpinnings of healthcare disparities.
So each of our study sections are, the direction that we're trying to go is to have each of our study sections really be able to evaluate health disparities on a number of different levels. So we have our community level, our study section that deals with sort of community level interventions. And if there are applications that are looking at health disparities at the community level, it would go to that study section. If there's an application that's looking at the systemic issues around health disparities, but at the sort of access to care or the quality of care, that would go to our health disparities study section. So depending on the focal area of the application and at what level they're looking at health disparities, we would put them in the relevant study section. I'm not sure if that's answering the question, but at least the way I'm understanding the question.
Yes, thank you. Another question, what study sections are appropriate for large observational studies?
So it depends on the unit of analysis. So we have our population sciences and epidemiology, IRG, that's looking at sort of large population level or epidemiological evaluations. The risk promotion and behavior change IRG looks at kind of at the individual level, and it could include large populations, but it's really sort of focused at the individual level. And then the healthcare delivery methodologies IRG focuses on the community or system level analysis. So it kind of depends on where the sort of focus is in terms of where which IRG we would place it in and which study section we would place it in.
Great. And what will happen to applications that were reviewed by old study sections that are being resubmitted? Will they have the same reviewers?
So we don't really, our goal isn't continuity of reviewers, it's continuity of review. And so even with our past study sections, if an application was a resubmission, if it would be assigned to the same, it may be assigned to the same study section. It may not, but it may be assigned to the same study section. But each round, the study section, with the addition of ad hoc members, the study section composition changes. So the likelihood that it would be assigned to the same reviewers is not necessarily high. So, you know, each round, the application gets assigned to the reviewers that are within that particular, that have been recruited for that study section for that round based on the expertise needed. And so with the new study section, the application will be assigned to the study section that is of best fit. and that has the appropriate expertise to review the application.
Thank you. And what is the best way for an investigator to determine which of the new study sections best fits their application?
So we have an ART tool, assisted review tool that applicants use in the past to kind of get a sense of what would be the best fit. That tool was based on prior applications, and it's based on an algorithm based on prior applications. So for the first few rounds, that tool, you can use that tool. However, it will direct you to the IRG level rather than the individual study section level. So the best advice I would give is to look at the study section descriptions on our website and get a sense of sort of what the best fit would be for your application. But also know that when we receive the application, we do a very thorough review of the application on multiple levels to assess where the best fit would be. And we are very knowledgeable about sort of the guidelines and the stretch points for each of the study section. And so we will assign the application to the study section that we feel would be the best fit based on our knowledge of the study section and what's being proposed.
Wonderful. Another attendee thanks you for a helpful talk. And could you please describe the distinctions between the more clinically focused study sections, CMGC and ICSC, especially when the proposed research has intersections between those two foci?
Mm-hmm. That's a great question. So on a sort of broad level, the biggest distinction between those two is really sort of where the care is being provided. So if it's a clinical management application where the care is being provided in a general care setting, a primary care setting, then it would go to CMGC. And let me move back here to give you and then if it's really focused on sort of the institutional or inpatient settings, hospitals, nursing care, inpatient care settings, it would be in the ICSC. For applications where where they may involve multiple care settings, we would place it where the most emphasis is. So if the most emphasis is in a clinic and inpatient facility, then it would go to the ICSC. So it just depends on where the emphasis, where the primary aims of the application seems to fall the most heavily.
Thank you. And would you share how applicants who are unsure of the right study group match can seek CSR or SRO help prior to submitting their application?
So if you go to our website, there will be, and you look at the actual links to the study section, there will be a link to the SRO who is managing that particular study section. You're more than welcome to reach out to that SRO, send them your specific aims and ask them, these are specific aims. Would this be a good fit for your study section? Again, we can't necessarily say exactly where your application would go until we receive the entire application and we've had a chance to really do a deep dive. But the SRO can give you a sense of, okay, I think this would be good for this study section, or you may want to think about this other study section as a fit. So you can always reach out to the SRO to have a conversation about study section fit.
Thank you. How does an applicant identify if an upcoming study section has the palliative care expertise needed for their particular application?
So our study section rosters are posted for the individual study sections about 30 days before the meeting. So each of our study sections have a standing panel, but each round, based on the range of applications that come in, we recruit ad hoc reviewers. And so usually the panel is set up about a month before the review meeting. And so you can always go online, take a look at the roster for that meeting 30 days before the meeting. Sometimes applicants will look at the roster for the prior meeting. That has its pros and cons because, again, each round we recruit reviewers based on the range of applications that we get. So if you look at a roster from the prior round, there may not be the same reviewers for this round. And so we always say that, you know, take a look at the roster for this particular, for the round that your application's in, and those are usually available 30 days before the meeting.
Thank you. Another question. Using CBPR, we develop interventions for healthcare in partnership with communities, cultural-based interventions, and then test feasibility of implementation in the healthcare system. Which study section would this fit in, as it seems to fit across several?
Yeah, so it's hard for me to give advice about specific study sections without knowing the exactly what the aims are and sort of where the emphasis of the aims are. Our science and implementation in health and healthcare study section is really focused on sort of the implementation of already developed evidence-based interventions. So the application is really kind of developing the intervention and then examining the implementation of that intervention in a particular community. It most likely would go to our health promotion and communities study section. But again, it's hard for me to really give you a specific study section without reading the application a little bit and getting more knowledge about where the emphasis is.
Right, thank you so much. If you have completed ESI application and accepted, however, never received any training and or called, is there another stage in the application process?
So are you saying ESA, meaning you submitted an application as an early stage investigator? Or are you referring to our early career reviewer program where you applied to be a reviewer?
Delia, I'm guessing it's the latter.
Okay, so you applied for the early career reviewer program, but you haven't been contacted to serve as a reviewer. I think that's how I'm understanding the question. So we have applicants apply to the program, and each round we recruit 2 early career reviewers for each of our standing panels, depending on the number of applications in that panel. And SROs will go to the particular database that we have, where we have all the applicants, and based on what their specific expertise needs are, they will recruit from that. So if you haven't been contacted yet, you should be contacted because we do use a pretty significant number of early career reviewers each round. But sometimes it takes some time before they find, you know, the application fit for your expertise.
Thank you. Another question, is the cross-cutting integration of implementation science expertise in this large grouping of study sections also present in other large groupings, such as in the neuroscience or disease-oriented study sections? And secondly, how are reviewers with implementation science expertise being identified?
So I can't speak to the first question. I know from a sort of broader CSR perspective, we are trying to really identify some of these cross-cutting scientific areas that need representation across all the study sections. But for the healthcare delivery methodologies IRG, where we do get a lot of implementation science applications or applications that have some level or some integration of implementation and dissemination, we are trying to populate all of our study sections with that particular expertise. And in terms of identifying reviewers, SROs have a number of ways that they communicate with the external community There are a number of implementation science work groups that SROs are engaged in or work with to identify implementation scientists. We work with our institution program officers often to help us identify scientists within the community. So there are a number of different ways that we try to reach out to identify implementation science researchers.
Oh, great. And what is the interface between the Institute Program Officer and the CSR?
Interface. So, at NIH, we have this two-tiered grant evaluation system where we have the scientific and technical review of the applications that for the most part occurs at CSR, although there are some reviews that occur in the institutes. And then once that occurs, the applications go to the institutes and where they are kind of managed by the program officers. We are structured so that we keep a pretty solid wall between program and review to make sure that we are really attuned to the potential for bias and we keep the integrity of the peer review process pretty sound. So while there is some interaction between review staff and program staff, we do try to keep those boundaries pretty solid. So I'm not sure if that's answering the question, but.
Thank you. And you may have mentioned this before, but will these new study sections be populated with reviewers from prior study sections?
Yes, and so most of the reviewers for the new study sections will be coming from our current study section members. And we will kind of place them in a particular study section based on where their expertise best fits. And then over the next couple of years, we will continue to populate the study sections so that they represent kind of the range of expertise that we need and can manage the number of applications that we get for each of those study sections. But initially, they will be populated by our the current study section.
Thank you. And what are some suggestions for study sections for proposals that include web-based interventions?
So again, it depends on the level of development. As I mentioned, we are populating all of our study sections within this particular IRG with mHealth expertise and some bioinformatics expertise. So if it's really about sort of developing the structure, the infrastructure of the technology, it would go into our two bioinformatic study sections. But if it's a community-based intervention that uses mobile health or that uses sort of a mHealth approach, it would most likely go into our community level intervention study section. So it kind of just depends on the developmental phase of the particular tool.
Thank you. You mentioned an individual being able to select a study section and also that your group will put where it's the best fit. Is it okay to ask who has final say in which study section it goes to?
So our Division of Receipt and Referral has final say. And so our process is usually, if an applicant requests a particular study section, we try to honor that request as appropriate. But if we get a request for a particular study section and we feel that, that study section isn't the best fit based on what the application is proposing to do and based on our understanding of the study section, we will place it in what we think is the best study section fit. Now, if the PI disagrees with that, the PI can contact the chief of that particular IRG. So for HDM, it would be me. And we will have a discussion about sort of why you as a PI think that it's not in its best study section placement and what you think would be a better placement. And we'll have that conversation. Often I will engage the other chief for the study section of interest. And if we can't get to a point of agreement, then there is a process in place for you to appeal our decision to the Division of Receipt and Referral. And they will take another look at the application. They will evaluate the arguments for the various study section placements, and they will make the ultimate decision about where the application will be placed.
Thank you. For ESI applications, is the ESI status considered immediately at initial study section review or only if scored?
So it's considered in the sense that we cluster the early stage investigator and the new investigators as a group for review. So we cluster those applications together when reviewers are given instructions for the discussion of the application. We tell them that, you know, this cluster of applications that are being reviewed are from early stage new investigators, and that they should keep in mind that developmental process, you know, that they may not have the same record of publications or of funding, but what really they should be looking at is whether they have the appropriate team, whether they've pulled together the appropriate team to be able to do the proposed work. So in terms of review, they are considered as a cluster. They are reviewed together as a cluster. And that's how we sort of consider early stage new investigators in review.
Thank you. Another good question. Some of these new study sections cover very large areas of science. Do you anticipate that some of these sections will need subsections or multiple study sections to review all the grants?
No. Part of our both external and internal sort of working group process was to really figure out how best these study sections should be organized so that they can be feasibly managed within a particular study section. And so the formation of these study sections really does reflect a very thoughtful, analytic evaluation of what the numbers are, what the range of science is within each of these, and the capacity for each study section to be able to manage the range of applications that come in. So we are pretty confident that these study sections, as they are comprised now, can effectively manage the range of science that comes into each of them.
Thank you. Could you please clarify what are the do's and don'ts of making an outreach, the SROs, or types of inquiries and unique roles of SRO versus program directors?
So in terms of the application assignment, SROs have a better understanding of the study section guidelines, the boundaries across the various study sections than the program officers do. And so usually we recommend, if you have a question about where the study section, where the application should be reviewed in terms of a study section, that you contact the SRO. If you have a question about which institute your application should be assigned to from a funding perspective, then you should contact the program officer. Program officers are also available to applicants to talk about sort of the scientific fit of what the applicant's proposing to do with the programmatic priorities of that particular institute. And so when you're trying to think about whether your application fits the programmatic priorities of a particular institute, you want to talk to the program officer. If you're interested in sort of what's the best study section for your application to be reviewed in, then you could contact the scientific review officer for the various study sections that you are considering.
Thank you. For ESI investigators' first-time application in the coming months, What are some particular places to navigate this change?
So if the question's related to navigating which study section to request for your application, the best tool would be to go to our website and just look at the study section descriptions to see which study section seems to fit best for your application. And you can include those, and you can include more than one. So if there's 2 or 3 study sections that you think would be a good fit for your application, on the study section request form, you can include those 2 or 3. But do keep in mind that we do a pretty intensive job at looking at the applications, looking at your specific aims, your research design to see where the best fit for your application would be. So you can request a particular study section, but you don't have to. We will always take a look at the application to see where we think the best fit would be. Again, we take PI considerations and PI requests in mind, and usually there is a fit between what the PI thinks would be a good fit for this studies for the application and what we think is a good fit for the application. But again, you can take a look at our website. You can click on the links for the individual study sections. And there's a pretty a thorough description of what the study section covers. And you can use that to come up with some ideas about where you think would be the good fit, the best fit, and just include that in your study section assignment request form.
Okay, thank you. I see one more question. Do these study sections apply to the SBIR/STTR submission?
They don't. So these are our standing study sections that really focus on the R mechanisms, the R01s, R03s, R21s. The SBIR applications and the fellowship applications get reviewed in a separate SBIR focused study section. The SBIR applications that are informatics focused, we have a special emphasis panel that looks at the informatics related health services research SBIRs. And then we have a broader SBIR study section that's based in RPHB, the RPHB IRG, that takes the SBIR focused applications that deal with health services research, population-based research, and risk behavior research, and reviews them as a group in a special emphasis panel.
Thank you. And a last question, can you discuss further about how the study section and institute interface? For instance, if I requested NIA, do study section reviewers take the institute's priorities into account?
No. So that's really a programmatic issue that gets reviewed at the institutes. What we ask our reviewers to do is really just evaluate the science proposed. Once they've done that and the application goes to the assigned institute, the institutes really determine whether there's a good programmatic fit with what's being proposed and what their priorities are. Which is why we always recommend that applicants talk to program officers within the particular institutes that they're interested in submitting to make sure that there is a fit for what they're proposing to do and the programmatic priorities of that institute. But from the review side, we are really focused on what's the scientific and technical merit of the application, and we don't consider institute priorities in the evaluation of the application.
Well, Delia, we are so grateful for your time and incredible navigation of all these questions to this audience and to this group. We really appreciate your helping us understand some of these changes that are going on and also giving people guidance on sort of where to go to get additional information as they're putting their proposals together. So thank you so much for your time and for giving this really incredibly valuable presentation to us. And I'll turn it over to Naomi to provide us with some final announcements.
Thanks, Dr. Ritchie, and thank you so much, Dr. Olufokunbi Sam, and to everyone who's joined today. If all of our attendees do go to our website, we have 2 more webinars that are posted for the near future. Next week, actually, we have Drs. Marie Bakaitis and Jennifer Temmel speaking on managing research teams. And then in October, we have Dr. Ronit Elk to discuss the critical role of understanding and respecting culture in palliative and end-of-life care, thinking about our African American patients. We hope that you join us for those as well. We'll also be sending out an evaluation where we gather other topics that you might be interested in learning about. So please take a minute to fill that out. Thank you again to our panel and for all of our attendees for joining today. Take care, everyone.